So it's 3:45 p.m. and our session, plenary session number 4, will run from 3:45 to 4:15. My name is Ivan Villespin. I'm a faculty member of this medical school, UST. And my task is to introduce my speaker. But before that, I'd like to start off by asking an honest-to-goodness answer by show of hands. How many of you have heard about electromagnetic therapy? How many of you here? One out of, you're probably about 100 or 80. Not bad. So I feel good now. Kala ko ako lang, I don't know anything about electromagnetic therapy. And worse is, I'm not even sure. I'm in awe of why a pulmonologist like me will be talking about diabetes, hypertension, and electric and magnetic field. I really do not know why. But for this session, our objectives are to present the evidence on the health benefits of this modality, which is not yet, I think, in the mainstream, unless you will tell me I'm wrong. An ongoing study on EMT as a model for studying nonconventional therapies, and he will present to us some preliminary data on the effect of EMT in diabetes and hypertension. Wala bang kasali si OPD dito or TB? Talaga ha? Ladies and gentlemen, our speaker is Abundio Balgos. He is the President and Chief Executive Officer of the Health Centrum Hospital and Wellness Center in Rojas City. It's a hotel and retirement village as well. It's being touted as a medical tourism park. He's our past president, Philippine College of Chest Physicians. Eric Morales, our current president, that fat one. Member of the FPCCP Council on ILD and Occupational, andyan ba siya? I thank you. Lung diseases. And is a member of the FPCCP CHIME. His distinctions include 2015 Exemplar in Clinical Practice awarded by the Philippine College of Physicians, and the 2014 Distinguished Alumni Award for Public Health Promotion, UP Alumni Association. He has a master's degree in hospital administration. That's why he's running his big hospital there in Panay. He has a postdoctoral fellowship in pulmonary physiology, University of California, San Diego. Halos sabay kami doon. He was in the west side kay Dr. West, and I'm on the other side, on the clinical side. He had his fellowship in pulmonary medicine, UP, Philippine General Hospital. Ladies and gentlemen, I must admit to you, I am in awe and I adore this guy. Let's give him a warm welcome, a Tomasian welcome, Abundio Balgos.
So allow me to start by answering a few of the questions that Ivan posed. Why is a pulmonologist involved in electromagnetic therapy? And why is it not on a pulmonary disease? To tell you frankly, just like most of you or all of you, I also did not know anything about electromagnetic therapy until the makers of this machine came to me and talk to me about the benefits that it has. And just like many of you, probably my immediate response was, show me the data, show me evidence. And indeed, I was given a brochure, but it's mostly anecdotal data. And as someone from the academe and who has done research, my immediate response was, I probably will not choose this. On the other hand, however, basically because of 3 reasons. First, because I'm really a naturally curious guy. I wanted to find out what it's all about. And 2, because I'm an internist, not just a pulmonologist. So I was looking at the indications for this device, and it included a lot of things, neuromyopathic disease, cramps, joint disorders, diabetes, hypertension, deep vein thrombosis, and prostate problems. So I told the guy who was showing me the machine was, come back after 1 week and I will tell you if I'm interested. And so basically what happened with after the guy left, because of internet, I started looking up information about electromagnetic therapy, and that's what I'm gonna share with you this afternoon. No? So in Tagalog, kuryente at batubalani, nakakagaling nga ba, no? So the curiosity in me started to draw the interest, and I looked at what is it in the literature. Are there really some evidence? Because what I saw in the brochure were mostly, statements of people who got well, which is 1 or 2 persons, 3 persons, and so on. No? Which, as you know, from the scientific and from the ethical point of view, from us in the academic world, it's not acceptable. Although I must admit to you that I'm already a retired faculty member, so I'm not an academician anymore. Just a few disclosures. I've done a lot of pharmaceutical research. I actually am doing the study itself of this device, so that is actually my conflict of interest now. But I will assure you that I'm going to show you the data as objective as possible, depending on what we have seen. So my objectives this afternoon is to present the evidence on the health benefits that I saw when I was searching the literature, and then to present to you the format and the actual conduct of the study that I did for this machine, and to, in the last part of the presentation, present the preliminary data of the ongoing study on patients with diabetes and hypertension. So allow me to first, let you go with me when I was browsing through the literature. So I first looked at the keyword of electromagnetic therapy, and what I saw was initially electrotherapy and then magnet therapy before the electromagnetic therapy. So apparently it came from electrophysiotherapy first. And apparently as early as the 1940s, the US War Department already used electrotherapy. They actually mentioned it as a galvanic exercise, and I will mention it to you later on. This is where what mainstream rehabilitation is using now, which is the TENS. No? So it came from a quote-unquote quackery concept, but has become mainstream. As you go through the literature, there are some really weird studies. For example, in a 1985 study, they actually reported a shrinkage of tumor cells in animal subjects. So again, if you are from the academe and you look at the research data, and how could electrotherapy do this? No? So one of the things that I can probably share, especially with our younger colleagues here, is I think we must have an open mind, because many of the discoveries, including, for example, cancer treatment, they came from herbals. Many of the discoveries came from data from Indian medicine, from Persian medicine, as mentioned by Dr. Matsukane earlier. So maybe a lesson that I can probably share with you here is maybe we should keep an open mind of the different technologies that may have no evidence base yet. But the key here is that my attitude was being not to shun it, but try to see and whether or not we can study it the way we study all other evidence-based practices that we are using. And hopefully, we can contribute to medical care, because if this indeed has some health benefit, we would have missed it. If Ivan would have studied this and developed a new machine, we could call it the Villespin electromagnetic therapy machine. No? So in 1999, a meta-analysis found that electrotherapy actually could speed the healing of wounds, and it created a lot of interest. And there are more than 1,000 studies that were done on electrotherapy because of this in 1999. However, just a year after, a Dutch Medical Council meta-analysis showed that there was insufficient evidence. So this is, again, just showing to you that you need to study the literature and you need to study the data, just like what Dr. Dans mentioned earlier. But the key thing is you have to keep an open mind and see what we can do with whatever new therapeutic, whether Western or alternative or integrative medicine has to offer. When I started to go back to the literature, the earliest scientific explanation that they were giving about the mechanism of action of electrotherapy was in 1984, so it's not so old. And they actually, the group of Nocitelli from Italy, showed that in all living organisms up to the cellular level, because of the presence of ions in the cell membrane, there are really charges. And there are endogenous weak electric fields that are present in the mitochondria and even in the cells. So I think that's something that all of us who have undergone physiology will accept. In fact, the transmission of neural impulses is actually electric in nature. So the body uses electricity or biocurrents as part of its mechanisms for controlling growth and repair. So it's not just cytokines, it's not just the endohormones or other chemicals. And the other thing that they have also found, especially the group of Bergens, is that the cell membranes are naturally capacitors. Those of you who are familiar with electricity, capacitors are those that can store energy and they can release it anytime later. And it's a concept that it's actually a mind-boggling concept for us who are regular clinicians who do not look at this capacity of all the living cells in the body. And Becker is a physicist, but he has worked a lot with doctors and he has done many studies. And he showed in animal studies that it's not only the neurochemical regulators that regulate homeostasis. There's also a lot of mechanical, electric, and magnetic signals that are going around the cells inside the body. So therefore, if you now change your mindset and look at this, you now start wondering why. Maybe it's possible if we can put in some electrical current or some magnetic influence to the cells, they might do some physiologic effect. So electrotherapy actually is one of the modalities that have actually gone to mainstream. Initially, they used it for pain management, but later on, they found that if you do DC small microampere currents to stimulate the nerves, you can actually improve strength, motor control, retard muscle atrophy, and improve local blood flow. And this is basically mainly electrophysiologic. So this is not touching yet on the magnetic side. It's really just electrical impulses. And they have established that it's a 0.1 to 10 microamperes. So very small voltages are able to stimulate the nerves and the neurons. It can improve range of joint mobility, and more importantly, later on, they found that it enhances tissue repair. So they have used it in near amputated limbs and those that have poor perfusion. They actually do not know yet the exact mechanism for the improvement in the microcirculation, but it does have some data or evidence about improving the microcirculation. The other use for it that has gone into mainstream is really the use of electrotherapy in deep brain stimulation. And there are many centers in the US as well as Europe. And I don't know if you're familiar with the X-linked dystonia Parkinsonism syndrome in Panay. They call it the Lubag of Panay. I have actually witnessed, the XDP clinic is now in my hospital. We have 200 XDP patients who come to us regularly. 13 patients have been sent to Germany for deep brain stimulation. They insert electrodes to the corpus callosum, and there are actually impulse generators that are put on the anterior chest. 12 out of those 13 patients came back with no motor disturbance anymore. So again, this is electrotherapy that has moved from quackery, if you may, to mainstream. Of course, it's very expensive still, no? So it may still take a lot of time I think Cardinal Santos does this, and the patient actually has to spend around 500,000 for implantation of this deep brain stimulation and the impulse generator. What are possible uses that I have seen in my review of the literature? They say that it can be used for treatment of acute and chronic edema by accelerating absorption rates of fluids, improving blood vessel permeability, and increasing mobility of proteins, blood cells, and lymphatic flow. And they have animal studies to show this. Again, they also induce arterial, venous, and lymphatic flow improvement. So, Ivan, if for patients with DVT, this is probably something that you can use. One of the uses that have actually gone into mainstream is actually the use of iontophoresis for excessive sweating of the extremities. And there are actually good clinical studies on this. They actually use very low voltage. The hands are immersed in water or saline water, and again, microampere electrical DC currents are put. So again, I must warn you that some of the treatment effectiveness mechanisms are still little understood, but it doesn't mean that us who are in the scientific and medical field should not look at this, because as again, we should be open to all the possible health gadgets or health benefits that we can get from the complementary treatments that we may come up. Very disturbing data that I saw was a series of maybe around 10 studies, both in vitro and later on very preliminary data, where using 50 to 100 microamperes of DC current, they actually were able to decrease the activity of viruses, including HIV. So we don't know whether future studies might prove this. Maybe you can relate this to the infectious disease specialists in the university and the College of Engineering. It's actually going to be a multidisciplinary approach if you're going to do this. So for the young medical students, this is a good possible research topic that you might want to look into. Now let's go to magnets. Dr. Parkas and I, at one of our conventions, were actually victims of this. Someone who was selling the quantum pendant demonstrated to us, and because they all bought, I was one of those who was gullible enough to buy. It's very expensive, mind you, no? But also, this search on the literature gave me the opportunity to look at what really does this, magnet therapy do. And apparently, what is going on is the magnetism can actually influence the electromagnetic forces are not only in the bloodstream but also in the areas around the cells. Now, are they working? In my review of the literature, this fixed magnet actually do not work. And the data from Becker shows that what is important is there are pulsations or the electric shocks and or the magnetic energy that is going to be put should be pulsatile. It should not be constant, because the effect on the cellular membranes are different, and there are the physicist talks about resonance of all of these electrical and magnetic forces, and if it is a constant energy, it does not work. So those of you who have this, or those of you who are planning to buy, my review of the literature shows that there's really no data even in the animal studies. The most common suggested mechanism that they say is to improve blood flow in underlying tissues, and as I've already shared with you, it's actually the pulsatile magnetic energy that seems to show some promise. And in these fixed magnets, the field surrounding magnet therapy devices is far too weak. Now, let me now go to my basis and why I say the pulse magnetic therapy is the one that has some promise. No? And they showed that, as I mentioned, there's a property of resonance according to the laws of physics, and a constant magnet energy is not going to be of any help. And this special resonant frequencies is what distinguishes one device from another. So there are actually now at least 4 models of pulse electromagnetic frequency therapy, and some of them are already undergoing studies in other academic institutions in Europe and in the US. And as I said, the internal chemical regulatory forces are controlled by the oscillation. So therefore, that's the basis word. It has to be pulsatile. And the pulse oscillations have been identified. It has to be 100 to 300 kilohertz. And so for those of you who are interested to do studies, you think about 0.1 to 10 microamperes of electricity and 100 to 300 kilohertz of frequency. So you can talk to your engineering friends now in the university. Maybe some data could be gotten from this university. Are there already current uses? Yes. In orthopedics, they actually use this PMFT or PMT for treatment of non-union of fractures, failed fusions, and congenital pseudoarthrosis. So this has already gone into mainstream. For physical therapy, they also use this for pain relief and improved range of motion and suppress inflammation. What really amazed me was there was one mention about depression. And when I look at the literature, Stanford was doing studies on pulse electromagnetic therapy for transcranial magnetic stimulation for neuropsychiatric patients who have depression. And their preliminary data showed very good data, but the numbers are still small. And these are PET scans of the effect, and it shows that in that arrow there, there's an increase in the area where they put the electromagnetic stimulation. So my point then was, if Stanford is studying this, why should I not do this? No? My only problem is, as mentioned by Dr. Ivan, I did not see anything on COPD or asthma or TB in the data. But I still wanted to find out if this therapy would work, and therefore I chose to look at diabetes and hypertension because we have many, believe it or not, we are seafood capital, but there are a lot of diabetics and hypertensives and many have high cholesterol in my province. And the device called MTech actually not only puts in pulse magnetic therapy, but it totally combines heat, far infrared, and electric therapy. So it actually is only one of the 4 machines available that actually combines 4 modalities. And this is how it looks like. The platform where the feet are put on actually is warm, almost hot, but it emits supposedly electromagnetic radiation and far infrared as well as heat therapy. And in Singapore, where actually this product comes from, it's actually a German design, but made in Singapore. It's actually they have already license for use of this machine. So what I did was I made a randomized single-blind real-life study on the safety and efficacy of that pulse electromagnetic heat therapy, and I was able to convince the maker to make a sham machine. It looks exactly the same. It also has heat on the surface, but there's no infrared, there's no electromagnetic therapy. And you know now the reason why, because I wanted to do a randomized controlled study. And this is why the CHIME wanted me to share this, because it's it could be a good model for you to use whenever you're confronted with complementary or non-mainstream disease. Probably not to immediately refuse it, but keep an open mind and study whether it's going to do good or not. So these were the trial objectives. We wanted to compare the clinical efficacy between the active and negative, which is the sham control group, without interfering with the diet and maintenance medication. So this is a real life study. So the primary physicians who referred the patients had the liberty to do with what they're doing with their patients. We just added the treatment, which is actually not invasive. They would just sit on the machine for 2 hours daily during weekdays for 2 months. I will describe to you later on our problem with patient enrollment, because not too many people would like to sit for 2 hours for 2 months, from Monday to Friday, and then to compare, describe the adverse reactions noted. From the manufacturer, the common complaint they say of those who undergo this type of therapy is they actually feel dehydrated, they feel warm, and the advice is for the patients to continuously take water when they're having the therapy. So this is the randomized control study. We designed it in such a way that some of the patients will have the active machine first, then cross over on the second month to the sham, while the others would have the sham machine first, and then cross over to the active. And it's single blind, so I know which machines are active, but the patients do not. And when we analyze the data, we pull the data, and therefore that should remove some of the confounding variables, because it's the patient himself who is going to be compared with his own data in both the active and the sham group. So we actually started with the inclusion of 20 to 80 years old, but because of the nature of the requirement for time, we never had any patient below 55 years old, because all those who are working would not want to join our study, because they have to sit down for 2 hours with us for all the weekdays for 2 months. So this is a major problem. Actually, we've been running this study for more than a year, and we've only been able to gather so far 23 subjects. We made sure that they have a documented history of or current elevation of fasting blood sugar or hemoglobin A1C, or documented history of or current hypertension. And here's the problem: willing to come to the health centrum daily for 2-hour treatment during weekdays for 2 months. Of course, we had to exclude any previous history of heat intolerance, anyone who has pacemakers, severe or uncontrolled or unstable comorbid illnesses. So we actually did not take in those with very high blood sugars or very high blood pressures. And standard exclusions of anyone who's using drugs or suffering from malignancy or pregnant or lactating. So our design was very simple. We took informed consent, the usual physical examination, baseline blood sugar, creatinine, hemoglobin A1C, and ECG. And we just monitor the blood pressure daily with 3 BP takings every day. For this study, the machine was placed for 1 hour on the feet and for 1 hour on the kidneys. Don't ask me why. That's what the manufacturer said is usually done if it's doing it for hypertensive patients. And theoretically, it should, from my readings, it should work only on the feet. But the manufacturer says that 1 hour on the feet and 1 hour on the lumbar area. And you had to provide television set and reading materials to the subjects because people can get bored just sitting down for 2 hours. And this is our blood pressure data for the patients who were on the active group. You will see a big scatter of the systolic and the diastolic blood pressures. And from here, you will see that there were actually minimal changes on the systolic and diastolic pressures. The only changes that we actually saw was in 4 patients where the attending physician, remember, we were not intervening with what the attending physician would do. We were just monitoring. 4 of these patients who were on the active group underwent a decrease in the medications because of the better control of blood pressure. But that's only 4 out of 22 subjects. So the numbers are small. So my conclusion from this data so far is there's no significant effect of the MTEC. Now let's look at those who were on the sham. It's almost the same, except that the scatters were bigger. There were more patients who had higher blood pressures in the sham group compared to the active group. But if you compare the mean data of both groups, it's actually almost the same. And the reductions were actually not very big. So again, you can see here that if you compare the active and the sham data, there seems to be not much difference. So in terms of the hypertension so far, we don't really see a big effect of the machine. Now let's look at the blood sugar. The subject with the blue line at the top, the orange and the gray, were actually 3 outliers. Most of the subjects were clumped together closely, and the dark blue outlier actually was randomized to the sham control first. So the blood sugar came up from 11 to more than 12, and even when the subject has transferred to the active group, the blood sugar still continued to increase. And that specific patient, when we look at we interviewed that patient, was really not following diet, and the attending physician actually had to increase the oral hypoglycemics and eventually had to shift to insulin. So this patient is an outlier and probably really had very poor compliance. Again, remember, this is a real-life study, so we did not control the diet of these patients. So part of the problem of real-life design is really lack of control of some of the variables. The gray line had a very high sugar for starters. Went down fast from around 14 to a little more than 8. And then, I don't know, was with the sham first, went down, and then had a faster decrease when the patient transferred from the sham to the active group. But that patient actually, when we examined, was really, again, because the patient was in the study, was more religious with the diet. But if you can see the slope of the curve of the sham versus the one in the MTEC was actually narrower. So there was a more rapid decline of the blood sugar. Again, the orange one is another one that was problematic. That patient was from another doctor, but also eventually had to shift to insulin therapy. And you can see that the blood sugar kept on increasing, but this patient actually was on the active group first before he transferred to the sham. Now, if you look at the clump data, the decrease in blood sugar of around 1 to 2 millimoles happened in 48% of those who were in the MTEC group, while it happened only in 18% of those who were in the sham group. So you can see a trend here that there's really a decrease in the fasting blood sugar for those patients who were on the MTEC. The hemoglobin A1C data was also very similar. The blue and the orange are the ones that were problematic. But as you can see, for that orange patient, there was actually a bigger increase in the hemoglobin A1C in the sham group compared to the MTEC. And the slope of the increase in the sham group was actually higher compared to the one in the MTEC. Just like the data from the fasting blood sugar, there was also a greater increase, a greater decrease in the hemoglobin A1C in the MTEC group versus the one in the sham control group. So, to summarize, there are definite evidence on the beneficial effects of electrotherapy. Not all of the claims, but for some of the indications have already gone mainstream. Magnet therapy alone has had no definite evidence if they are fixed, but when you use pulse magnetic therapy, there are already increasing data, and there are now more academic research centers that are doing research on this. And there is some promise in certain therapeutic areas. The MTEC machine, which combines 4 of the modalities, shows that there's a significant downward trend, but the numbers are small, and we have some confounding variables that we are not able to control. And whatever data that we have, I don't think will allow me to conclude that I will prescribe this machine immediately. But you know, this actually is a stimulating event for me, because now I'm talking to the maker that maybe we can do a multi-center trial involving UST, UP, many other academic centers, and do more studies on this, because after all, we might, just like Stanford, be, you know, going into some areas where they have not done the studies before. I'd like to end my talk by sharing with you that those of us who were trained in academic and scientific thinking, we seem like to have blinders, and we just look at studies that are 6,000 subjects with controlled randomized trials. But there are many alternative or complementary medicine that has been used for centuries, and they just lack studies that should be done. And if we just keep an open mind and do more work, hopefully we can add more treatments to our armamentarium. Thank you for your kind attention.
It's 4:25. It's a plenary session, though, so there's no open forum. But I'm sure Dr. Balgos will be very enthusiastic and passionate in answering your questions. Paglabas mo na lang. So nothing to summarize, but I just want to reiterate what he repeatedly said at the start and the end of the lecture. Please keep an open mind about things. What we, you know, before we were thinking that with regards modalities about science, they were the myths. What was considered a myth before became a fact now. But what is a fact now may actually be a myth in the future. Anyway, I'm very optimistic about this one, and I'd like to share those testimonial successes that you did mention. And I'm hoping that this will be able to penetrate mainstream medicine, and let's have collaborative partnership, and hopefully, who knows, we might be seeing some things that we always allow the Westerners and the other countries to report successes, but this time let's allow our country to do this. Thank you very much, and good afternoon.